Welcome to the Colorectal Conversation, Getting Candid about Colon Health. This program is brought to you by Northern Westchester Hospital's Cancer Treatment and Wellness Center and the Center for Healthy Living. I'm your moderator for tonight. My name is Dr. Alexis Grusella. I'm the Chief of Colorectal Surgery at Northern Westchester Hospital. With me are two panelists and my colleagues, Dr. Eli Abemeyer, who's the Director of Northern Westchester Hospital's Gastroenterology Division. Hello, Eli. What's your role as a GI physician?
Hi, Alexis. Thank you for having us tonight. I'm Chief of the Department of Gastroenterology. I perform colonoscopies and oversee a department where we diagnose and treat colorectal cancers.
Great. And we also have with us Dr. Paul Strombaum, who's the chair of the Phelps Cancer Committee and a colorectal surgeon at Phelps and Northern Westchester Hospital. Hello, Paul. Can you describe your role as a colorectal surgeon?
So my role as a colorectal surgeon generally is to actually perform the surgeries to remove colon cancers and rectal cancers and hopefully cure some of these cancers we're going to talk about tonight.
Great. Okay, so education and action. These are two of the most powerful tools for reducing your risk of colorectal cancer. This month, as you may know, is Colorectal Cancer Awareness Month, and there's no better time to have a conversation about this topic. Tonight, you will learn the facts about the latest colorectal cancer screening and prevention recommendations, including facts about diagnosis and advanced treatment options and the role of nutrition in prevention. Take action to protect yourself and those you love. With proper screening, colon cancer can be detected early and is often curable. You can schedule your colorectal cancer screening today. If you want more information or to schedule an appointment with one of our physicians, you can call the number listed or visit the website that you see on your screen. Here's some general information about our program tonight. As time permits, at the end of the program, we will take questions and answer some of your pre-submitted questions from registration. Please put all questions in the chat or QA function. At any time during this presentation, if you're interested in booking an appointment, please private message us using the chat function with your name and contact information. One of our providers will contact you for assistance in answering your questions or booking your appointment. You can also provide your contact information in the survey at the end of this program. Your information and name will be kept confidential. Let's get started. Dr. Strombaum, when we discuss the term colorectal cancers, what are we referring to?
Yeah, so when we're talking about colorectal cancers, it means cancers found in the colon or rectum. And sometimes these colon and rectum are referred to as the large bowel, which makes up the last 5 to 6 feet of our GI tract. It's basically where all the food that we eat and drink and gets broken up turns into stool before we pass it out with a bowel movement. And when we specifically talk about cancer, we mean a tumor or a mass that may be found and it looks abnormal under a microscope with the potential to spread to other parts of the body.
Okay. Dr. Abemeyer, how and when do we screen for colorectal cancer?
So the standard of care had been to start asymptomatic people at age 50. That was very effective in terms of diagnosing cancers and polyps. And as a consequence, recently the recommendation has gone to screen all people at age 45, even if you're asymptomatic. There's special groups of individuals who we would start screening earlier, but typically age 45 now would be the time to get a colonoscopy, which is still the recommendation for most people, since it has been proven to be the most effective form of screening for colorectal cancer.
Okay. And so is colonoscopy, in your opinion, the best way to screen for colorectal cancer?
I think in terms of identifying early polyps, which potentially could become cancer, it clearly is the best option for finding those. Plus, it also provides the advantage that you can remove the polyp when you identify, when you find it. So I think still at this point in time, most people are recommending colonoscopies for their patients, and that still remains the standard of care.
So just to make sure the folks at home realize or understand, a colonoscopy can not only diagnose colon cancer, it could treat a polyp or prevent colon cancer from happening in the first place. Is that right, Dr. Abemeyer?
Yes, so that really is the main advantage to the procedure, that you can do both diagnosis, where it still is preferable in terms of finding things compared to other options. But in addition, you also remove the polyp, so you eliminate the risk going forward of cancer developing in that polyp. Plus, it also allows you to diagnose other illnesses and other conditions that people may have.
Okay. And Dr. Strombaum, what are the new screening recommendations for colorectal cancer?
Yeah, this is an important question since the recommendations have recently changed. Dr. Abermeyer just touched on it briefly. So we used to recommend that people be screened at age 50, generally speaking, but those recommendations have recently been lowered to the age of 45. And the main reason we made these changes is because we're seeing more and more colon cancer in younger patients. And so we're hopefully going to prevent some of these or catch them at an earlier stage when they're easier to cure. I think the last thing importantly is that for patients who do have symptoms already like bleeding and other things like that, we don't recommend waiting. Everyone should get a colonoscopy if they have other symptoms going on.
Right. And so it's really important if you think you have any concerning symptoms, which we're going to talk about, to talk to your doctor, and a colonoscopy may be warranted for you. So Dr. Abermeyer, are there any alternatives to colonoscopy for screening?
There are. I mean, let me just preface it by saying the most important thing that anyone can do is just do something for screening. So that, I think, is the most crucial kind of decision. After that, I think that you have to look at what best suits the individual. In general, as I said, most people are being advised to do colonoscopy, but the alternatives are either less invasive or they're tests which are better for people given other medical illnesses that they may have. So one option is what's called a CT colonography or a virtual colonoscopy. So that's an X-ray test. People still need to clean out for this procedure. So in most cases, that's the worst part of the whole, kind of encounter. But they would clean out, and then they would go through a CAT scan machine, and they would then have the image of their colon recreated. So that's one option. That does not give you the opportunity for any therapeutics. It just does diagnostics, and it's not quite as accurate for small polyps. Another option is just testing for blood in the stool. So that's a hemocult test or a fecal immunohistochemical test, an FIT. And that's something which looks for blood, and that's something which would be done either annually or if it's coupled with a sigmoidoscopy, which is a short tube looking into the left side of the colon, that could be done at 5-year intervals. And the final thing, which has gotten a lot of press, is something called a Cologuard test. And what that does, it looks for both blood in the stool as well as DNA mutations, two DNA mutations that may be expressed from a cancer. So that test has a very high predictive value for colon cancer, meaning that if it's positive, it has a high likelihood that it's a real positive test, that there really is a cancer there. But it is not as good in terms of finding polyps. So it misses about 1/3 of all polyps, which in most cases is the precursor to cancer. So you're not really doing a screening test to look for polyps. You're really doing a test to say, is there likelihood of being a cancer or not? And again, a false test does not necessarily exclude that there is a cancer there. But those are the main options now, I think, out there.
So what I'm getting from you, Dr. Abermeyer, is that all of these tests, although they are an option, don't have the ability to remove polyps, which are precancerous, which could prevent colon cancer from happening in the first place.
I think that's the big advantage of the colonoscopy, that you can diagnose and you can also treat. So I think that's why it's so still recommended as the first line intervention.
And I think one thing that patients often have a misconception about is the CT colonography or CT colonoscopy, because they don't want to take a prep, but you actually do have to prep for that test as well. It's the same prep. Am I right?
Yeah. So the prep again is typically the worst part of any kind of test for people, and you have to do the same prep more or less for the virtual colonoscopy.
Right. Okay, so Dr. Strombaum, what would you say to the people out there who are afraid of a colonoscopy or afraid of the prep?
Yeah, I think there's certainly a lot of rumor out there about potential dangers of colonoscopy or how terrible the prep potentially is. And I'd start by saying that the colonoscopy itself is really not something to be afraid of. The procedure is extremely safe, even in patients who have to have a polyp removed or something like that. And these days, most patients are getting their colonoscopy with sedation while monitored by an anesthesiologist. So the whole procedure itself is an extremely safe and easy experience. You're asleep for the whole procedure. You won't feel or remember anything really. With regards to the prep, it certainly can be unpleasant, as Dr. Habermeyer talked about. There are some other options that require a little bit less liquid to drink. So those are something to consider, especially if you had a bad experience in the past with some of the higher volume preps. Some of these can be considered and they're a little bit more tolerable.
Yes. Is there something called a split prep or where a Miralax prep, which may not be the same as drinking the whole gallon of Go Lightly or one of the other agents that people tend to be really not a fan of?
Yeah, so there's Go Lightly is kind of the older one that's a large volume. Miralax ends up about half as much volume. And there's some other even lower volume ones, I believe. I'm blanking on some of the brand names right now, but yeah, so those are some other options to consider.
So I would say to the folks at home, if you are avoiding getting a colonoscopy because you are afraid of the prep, talk to your doctor about some alternative options. And maybe this can help put some of those fears at rest. Okay, so Dr. Habermeyer, what are colon polyps and do they always mean cancer?
So polyps are growths that develop usually from some genetic or some mutation that occurs, allowing cells to multiply more rapidly. So when that happens, some of those rapidly dividing cells can become more abnormal and they can develop into precancerous polyps. Some just grow at a more rapid pace and they become like a mushroom in appearance, but they really don't have any cancer potential. They just are parts of the cells which have grown more rapidly compared to other parts. We can't tell just by looking at them, so we remove all of them. So when you look at people who undergo screening colonoscopies for the first time, and this was done in people age 50, about 40% of them had polyps of some sort. And of those polyps, about half of them turned out to be what's called adenomas. Those are the polyps that potentially, if left alone, could have developed into cancer. So it's a pretty large segment of the population. It's really like 20% of people undergoing their first colonoscopy who have no symptoms, no problems, and they have, polyps that potentially, if left alone, could have developed into cancer. So it's not an insignificant number.
And so if somebody has polyps on their colonoscopy, will that change their future interval for colonoscopies in the future?
So if somebody does have a polyp, we usually will bring them back sooner because for two reasons. One, you want to make sure that the polyp is completely removed. And secondly, you want to make sure that they haven't developed other polyps. If somebody has an adenoma or even a hypoplastic polyp, which is the type that doesn't go on to cancer, they have an increased risk of developing other polyps. There are other risk factors also, but that one in particular would warrant that people come back, at shorter intervals compared to someone who has no polyps whatsoever.
Perfect. Okay. Dr. Strombaum, what are the risk factors that contribute to colorectal cancer? And are there specific foods or things to avoid to reduce the risk of colorectal cancer?
Yeah, so one of the risk factors is certainly a family history of colorectal cancer, especially in those family members who had a cancer at a young age. Some other risk factors include smoking, a diet with a lot of processed or red meats, obesity. As far as ways to reduce the risk of colorectal cancer, certainly not smoking, and then eating a balanced diet, a fair amount of fruits and vegetables with fiber can potentially decrease the risk of cancer. And then I think just lastly, just because you don't have a family history of colon cancer does not mean that you yourself cannot have colon cancer. About 80% of patients who have cancer themselves do not have any other colorectal cancer history in their family.
Okay, thank you. So to learn more about nutrition's role in the prevention of colorectal cancer, we will now show a video made by Amy Rosenfeld, a registered dietitian at Northern Westchester Hospital Center for Healthy Living.
Hello, my name is Amy Rosenfeld, and I'm a registered dietitian for Northern Westchester Hospital's Center for Healthy Living. Colorectal cancers are one of the most common cancers in the United States, and prevention is key. There are steps we can take in the kitchen to reduce our risk. Here are 5 ways to reduce your risk of colorectal cancers through food choices. The first tip is to eat lots of fruits and vegetables, a colorful variety at every meal. Try filling half your plate of fruits and vegetables and to eat the rainbow every day. Make eating fruits and vegetables easy, crudité, ready to eat. Try frozen fruits and vegetables to have on hand. Prep undressed chopped salads and trays of roasted vegetables, and try a variety of different methods to include in your diet. Next, choose whole grains as well as legumes such as beans and lentils. So many different types of grains and legumes to include in your diet. Include a variety. Try new ones that may be different to you, such as whole grain couscous or a new one like kasha or quinoa. Try to mix it up with your white rice. Mix in some brown rice or switch to brown rice. Switch to whole wheat bread as another choice. Mix in some beans and lentils into your meat-based dishes or swap them out for some vegetarian meals. Also incorporate nuts and seeds. If you can't have nuts, just have some seeds. Here are some interesting choices to try. Here's some ground flaxseed, as well as some chia seeds, as well as hemp seeds here. All are great options to include for plant-based protein and a good source of fiber. Choose fish, lean poultry, eggs, and plant-based proteins like your beans and your lentils as choice of proteins. Research shows that diets based in plant-based foods, fish, and eggs significantly reduce the risk of colorectal cancers. Start by having a plant-based meal a few times a week, or substituting in beans and lentils for some animal proteins. Have fish and eggs in instead of a meat choice. And overall, choose to have less red meat and processed meats, such as luncheon meats, hot dogs, and other processed meats. When choosing healthy food choices to reduce your risk of colorectal cancer, it's all about fiber. Researchers believe that fiber helps to add bulk to your digestive system, shortening the amount of time that waste travels through your colon and reducing your cancer risk. So try any of the options that we discussed today included in your diet, increasing your water intake to help your body along.
Wow, that was great. Thanks, Amy. We're going to keep going with our questions. So Dr. Abmeyer, who is at highest risk to develop colorectal cancer, and can young people get colorectal cancer?
So there are lots of risk factors that can contribute to colorectal cancer. So one is, as you've seen, the nutritional aspects. Another would be age, just getting older. As you get older, the risk for colon cancer and other cancers increases. Certain subgroups of people are also higher risk for colon cancer. So individuals with polyps, which again argues for screening, people with certain conditions such as inflammatory bowel disease, or certain familial cancer, colon cancer syndromes, such as Lynch syndrome, and people who have family history of colon cancer, just in first or second generation individuals. So all of those would be at higher risk, and we would screen them more aggressively. In addition, African Americans tend to get cancers that are more aggressive and tend to occur earlier. So they were screened at 45 years of age when other people were screened at 50 years of age. And that recommendation probably will change, I suspect, as the new guidelines take effect.
Okay. And Dr. Abmeyer, what are some GI symptoms that you should talk to your doctor about if you experience them?
So the symptoms are very varied, but people can, certainly look for things such as blood in the stool, unexplained weight loss, changes in their bowel habits, abdominal pain, bloating. And again, these would be things which aren't necessarily occurring, once, but they're trends. You look over time at things. So if somebody has some abdominal discomfort, it wouldn't be a sign of cancer. It's really the persistence of those symptoms or the persistence of changes in their bowel habits. So those would be kinds of, I think, some of the main kind of symptoms that people should be wary of.
Great. And Dr. Strombaum, how are colorectal cancers diagnosed and staged?
Yeah, so most colorectal cancers are usually diagnosed on colonoscopy. So the patient will undergo a colonoscopy, and a small piece or a biopsy of the tumor, if found, is taken and sent off to the pathologist, who looks at it under a microscope to identify cancer cells, which are basically cells that are growing abnormally. And if a patient is found to have a colon cancer, they usually undergo a CAT scan of the chest, abdomen, and pelvis to make sure that it hasn't spread anywhere beyond the colon. Rectal cancer gets a little more complicated, but essentially add an MRI of the pelvis, which looks at the tumor, how big it is, how invasive it is, and if any lymph nodes are involved in the pelvis.
Okay. And as far as staging goes, is there a good way to kind of visualize the stages, early versus late stage?
Yeah, so tumors of the colon and rectum are usually staged based on how deep the tumor goes into the wall of the colon. It goes from 1 to 4. Next, we look at the lymph nodes, which are kind of a drainage system from the colon or the rectum, and if those are involved or not. And then the last part is M for metastases, which means whether the tumor is spread anywhere else in the body, like the liver or the lungs. So each of those have their own numbers associated. And then depending on which combination you have, you get a stage from 1 to 4. Stage 1 being the earliest cancers, meaning the best chances of survival long-term after treatment. And stage 4, meaning the tumor is spread to other parts of the body.
Got it. Okay. And Dr. Strombaum, how is colon and rectal cancer treated?
Yeah, so they can be treated a little bit differently. Colon cancer is a little bit more straightforward. Usually, if the tumor is not spread anywhere else in the body, surgery will be the first line treatment for colon cancer. So a patient would undergo surgery, remove the tumor, remove the lymph nodes. The pathologist will check them under the microscope to see if any of the lymph nodes are involved. And if there has been tumor found in some of those lymph nodes, we usually recommend chemotherapy as the next line of treatment. And most patients that'll kind of be the end of their treatment, but we follow them for about 5 years afterwards. Like I said, rectal cancer gets a little more complicated because it's in the pelvis, a little bit trickier surgery. So sometimes radiation will be involved in treatment. Chemotherapy can be involved before surgery. And we have a multidisciplinary team that talks about that between all the providers that take care of these patients.
Great. But usually, if it hasn't spread beyond and it's not a stage 4, then colon and rectal cancer can be cured with surgery. Is that right?
That is correct. Yeah. Surgery is certainly involved for all these patients if it hasn't spread beyond or to another part of the body, and with high chances of success with surgery.
Great. And even if it has, there are options for sure.
That's true.
Dr. Abmeyer, how does Northern Westchester Hospital provide a team approach to treatment and care?
So they typically will make an effort to have many disciplines involved for treatment of care of colon cancer. There's an oncology navigator, which helps kind of coordinate some of this and draw people to various options if they are interested. There's the Yablon Cancer Center, which tries to look at a more holistic approach to the care. And there are people who stress nutrition or other less traditional kinds of options. And that's all done in the context of, a surgeon, an oncologist, maybe a gastroenterologist, all the individuals who are also, let's say, the more traditional individuals who would be caring for colon cancer patients.
Great. So it sounds like there's a whole team approach to cancer care at Northern Westchester Hospital, where it's everyone from the gastroenterologist who diagnoses it to the surgeon who could remove it and cure it, to the pathologist, the radiologist, and everyone in between in supportive care to help patients navigate through their illness to cure. Dr. Strombaum, what technological advancements does Northern Westchester Hospital have for surgery for colon and rectal cancer?
Yeah, great question. Certainly from a surgical perspective, we do have 3 surgical robots in the ORs at Northern Westchester. And these basically allow us to approach colon cancer and rectal cancer in what we call a minimally invasive fashion, using very small incisions and a small camera to go in and do the whole dissection inside the body, remove the tumor, and basically end up with a very small incision to take out that piece of colon or rectum. And these surgeries generally allow patients to recover faster in the hospital. We have early recovery pathways to get people up and moving after surgery to get out of the hospital in a faster and safer way. And basically, if patients recover faster from surgery, they're able to get onto other treatment if needed and have fewer complications.
So when somebody comes to your office and they need surgery for colon cancer, How long do they typically have to stay in the hospital after having a robotic surgical resection?
Yeah, so I tell most people on average somewhere between 2 and 5 days. Probably 2 to 3 days is more common for most patients. It does vary a little bit depending on where the tumor is and how quickly their bowel function recovers. But really, these aren't long stays, and they're getting up and moving around, the same day of surgery and feeling pretty good after surgery.
Yeah, it's amazing. I mean, we generally get patients out of the hospital after robotic surgery with 1 to 2 nights in the hospital. So this is really, an amazing technology where patients have less pain, have a faster recovery, can get back to life and work and school. And so it's really been a revolutionary, treatment for patients with colon and rectal cancer.
Yeah, I think.
So, oh, sorry.
I was going to say, to compare it to like when I was in medical school, patients were getting big open surgeries.
Yes.
We wouldn't let them eat or drink for 5 days after surgery. They'd be in the hospital for 7 to 8 days. So it's really come a long ways in a relatively short period of time.
Right. So it's true that patients can eat the same day or the next day after surgery. Is that right?
That is correct.
And they can get up and walk just as they walked into the hospital the same night after surgery.
Yeah, no laying in bed for 3 days, recovering from a big surgery. So
it's great. So Northern Westchester Hospital provides high quality care close to home. There's no need to travel to the city for your care. We are part of the Northwell Health family. We have leading cancer experts, access to clinical trials and technology, and collaborate within the Northwell system. So I think it's really important for patients to know that they have access to this entire system and doctors who were even practicing in New York City and now are practicing here, or are just as good, if not better, as physicians in the city. And we have an extremely strong, supportive team. And that's why I joined Northern Westchester Hospital. So Dr. Abmeyer, what are Northern Westchester Hospital's COVID safety protocols during screening, appointments, and surgery?
So, COVID, the recommendations have changed over time, and they'll continue to change. But I think Northern Westchester really has done everything they possibly could, and all mandates from the state to try to keep people as safe as possible. So typically, patients will be brought directly into the endoscopy unit. They'll try to keep social distancing. We've cut back in terms of the size of the waiting area, in terms of the number of patients who are either there before or after procedures. We try to keep family members and friends out of the recovery space so that we limit exposure to people. Everybody is still wearing personal protective gear. So all the staff are covered. Patients keep their masks on during the course of the procedure. We obviously are using the typical air handlers to siphon air in the rooms. We're cleaning the rooms down. We're keeping social distancing. I think we're really doing everything and more that would be required to keep things safe. And again, over time, now that people are getting vaccinated, these recommendations, I'm sure, will be changing further. And maybe we won't need to be quite as stringent going forward. But as it stands now, we're still kind of maintaining all of the recommendations we had even from day one. The only change has been that we're doing a larger volume of cases now, rather than just emergencies. We're doing elective cases and pretty much the normal flow of cases that we were doing prior to COVID.
Right. And I think it's important for patients to know that not only are they being tested for COVID prior, so all the patients are being tested for COVID prior to their surgery or procedure, but that many patients are now vaccinated and most of the staff is now vaccinated as well. So it's really become a reassuring environment for patients to have their colon and rectal cancer screenings and surgery at Northern Westchester Hospital.
Yeah, it's right. I think that's a good point, that the people are getting tested 3 days before the procedures as a mandatory thing, whether they've been vaccinated or not. I think, as you've mentioned, as more people get vaccinated, probably some of those recommendations will change. Whether we'll continue to test everybody is unclear, but as of now, that's what we're still doing.
Okay. And so, Dr. Strombaum, should patients with colorectal cancer receive the COVID vaccine?
Yes, I do believe that patients with colorectal cancer should still receive the vaccine. It's certainly not going to affect their care or their survival. It won't affect whether the tumor is spread anywhere else in the body. And if anything, getting the vaccine potentially prevents you from having complication from COVID that may affect, if you're getting chemotherapy or something like that. So if anything, I think it's beneficial to prevent you from having a break in your care.
Great. Dr. Abmeyer, what services does Northern Westchester Hospital offer to our community to provide financial support for colorectal cancer screening and treatment?
So through a community service program at the hospital, we've reached out to a variety of different groups in the community, Open Door, Neighbors Link, and we've provided a navigator who is bilingual, and typically bilingual. And we've reached out in terms of having a clinic that will either be of no cost to the patient or at a sliding scale, depending on financial ability. So we try to provide a clinic every week. We do it for usually half a day, where we see patients. We deal with both their medical issues as well as their financial needs. If they need a colonoscopy, those procedures are done at the hospital. And once again, they're done either without charge, or they're done with a sliding scale, depending on what their abilities might be. So we've kind of created this program, and we've continued it now probably for about maybe 10 years. It's been quite a while it's been in existence.
Okay. Dr. Strombaum, can colon and rectal cancer be cured?
Yes, it certainly can be. It is easier to cure when it's found at an earlier stage. It's one of the reasons we stress colonoscopy so much. But that being said, colon cancer and rectal cancer are very treatable cancers. For example, I had a patient in his early 80s who underwent a robotic colon resection. He fortunately had an early stage cancer, so he had a stage 1 tumor. So surgery was essentially curative for him. He has probably a 95% chance of living for the next 5 years without having any cancer come back. And he may live to 105 because he's such a healthy guy. So, that was a 2-day stay in the hospital for him. He's essentially cured from colon cancer, and I think he's gonna be very happy. So
that's great. So we're now going to move into our question and answer portion. And if you have any questions, feel free to submit. The first one is, Dr. Abmeyer, is there a connection between inflammatory bowel conditions such as Crohn's disease or ulcerative colitis and development of a colorectal cancer?
So when I was talking about high-risk groups, inflammatory bowel disease patients are considered a high-risk group. A lot of the studies with regards to the specific risk, how much greater, were done prior to the availability of a lot of the medications we currently have. So the numbers may not be quite as accurate today as they were maybe 15, 20 years ago. Nevertheless, it's clear that people with inflammatory bowel disease have an increased risk of colon cancer. And that's usually a function of the extent of involvement of their colon, the age that they were diagnosed, family members who may have had colon cancer, and the degree of inflammatory changes, the amount of inflammation that they're having in the colon. So all of those things kind of are modulators to the risk for them developing cancer. As a consequence, when people have 8+ years of colitis, of ulcerative colitis, we usually bring them back every 1 to 2 years for colonoscopies because their risk is sufficient to warrant putting them through the procedure. So we do monitor them more carefully. We try to really treat people who have inflammatory bowel disease in an effort to get their inflammation down, because we think ultimately inflammation is the bad thing, which leads to the cancer, and also obviously impairs just their day-to-day life among people who have inflammatory bowel disease.
Great, thank you for that. That reminds me of a patient story that I think is worth sharing with you guys. So I had a patient with Crohn's disease who was getting her regular surveillance colonoscopy, and it was always drilled into her. She was a young woman, how important it was for her to get screened because she was at higher risk. And she finally convinced her mother to have a colonoscopy as she was in her late 50s, early 60s without ever having a colonoscopy. And she was kind of tearing her hair out trying to get her parents to get screened. And her mom had a colonoscopy and unfortunately turned out that she had a colon cancer. It was early, stage 2. She came to me for a robotic surgery, did well, was cured. But while she was getting set up for surgery, she finally convinced her husband, so my original patient's father, to have a colonoscopy. And he ended up also having a colon cancer. He had a stage 1 cancer, also came for robotic surgery. One had a right and one had a left. He, the next month, had a robotic surgery, did well, and was cured. So they were both cured, did not need chemotherapy, had quick, easy recoveries with robotic surgery. And the daughter was so thankful that they, finally listened to her and went to get their screening colonoscopies. So I think it's a good message for folks at home that, it doesn't necessarily have to be a high risk. You don't have to necessarily have a high risk feature like colitis, Crohn's disease, or family history. It's still important to get your colonoscopy. And, the new age is now 45. So try to keep that in mind. So we're going to move on to another question. Dr. Abmeyer, are all colonoscopies performed in the hospital at NWH?
No, we can do procedures as an inpatient or outpatient facilities. It's to some extent patient preference. Some people just are more comfortable in a hospital setting. They don't really require to be in a hospital, but they just feel some degree of, if something should happen, they're there. But in general, people can have it done in an outpatient facility also, which is even, sometimes a little faster, a little less commotion, and it would be equally, an appropriate setting. There are some people who have the need to be in a hospital, comorbid conditions or sleep apnea, or if they're very overweight, those would be people who would be done in a hospital setting.
If you have a family history of colon cancer, what is a recommendation of family members to get screened?
So I'll take that question.
Yeah, that's perfect.
So,
yeah.
If somebody has a colon cancer at an older age, so we're talking about first degree or multiple second degree relatives. So grandparents, uncles, aunts, cousins, so multiple second degree. They would start getting screened at age 40, unless the person who had the cancer was younger than 50, in which case the screening age would be 10 years younger than the age of onset of cancer. So if somebody had cancer at age 45, you would start screening at age 35. So it would be either age 40 or 10 years younger than the index case.
Okay, that's very helpful. Thank you. I have another one for you. So how often do you need to get a colonoscopy? And the example is my last colonoscopy was 2013, and I was told I don't need one until 2023, and I had no polyps. Do you agree? So I think you can kind of break down the different, general intervals for folks at home.
So I'll tell you the current recommendations, and then I'll tell you my own bias.
Great.
So the current recommendations are that if you have a negative colonoscopy and you're an average risk person, you don't have any kind of the warning signs that we've gone over, you can have your next colonoscopy 10 years later. If you had a polyp, a single polyp, an adenoma, usually, unless it's very, very large, unless it was, had some features under the microscope that made it more worrisome, typically you would come back in 5 years. And again, if you had a very large polyp or a polyp that had what's called villus characteristics, or if you had multiple polyps, you would come back sooner. And sometimes you bring people back in a few months, because if it's a very large polyp or if it's situated in the colon in a difficult configuration, you may want to bring them back sooner to make sure it's all been taken out. So those, I think, are the recommendations that most people are publishing. I've told my patients that I usually don't like to wait 10 years. There's a certain number of polyps that are missed on the initial colonoscopy. Some studies have said about up to 6% can be missed. Those are not huge polyps. Those are usually very small polyps. But if the prep is not as good as it should be, or if there's a lot of movement in the colon, sometimes you just miss things. And so there is a miss rate no matter who does the colonoscopy. Plus, even if you don't miss anything, the average, the projection from going from an abnormal cell to a cancer is 10 years. So I don't really want to find a cancer, with all due respect to my surgical friends. I want to find a polyp. I want to take out a polyp and prevent it from developing into cancer. So I usually tell them somewhere around 7 to 10 years to come back. If I tell them 7 years, usually they'll come back at 8, 9. And I think that's the compromise I usually make.
Right.
Yeah.
So dovetailing off of that, there's a question, can you reduce the recurrence of polyps?
So that's a difficult question. So
Yeah.
there are people who have polyposis syndromes who have hundreds of polyps, and there are studies that put them on certain kinds of non-steroidals, and those seem to lower the number of polyps. So you wouldn't be on that kind of a medication unless you had just hundreds and thousands of polyps and didn't want to have surgery. Recently, there were studies that were talking about cancer risk among people who have taken aspirin. So baby aspirin or irregular aspirin. In the most recent studies, there's an argument that they potentially reduce the number of polyps that people can develop. So that's one possible thing. I don't think that's substantiated. And again, it's not standard of care, but it's studies that looked at that. They've looked at other things such as vitamin D. They've looked at fish oil. They've looked at lots of supplements. And none of them have really been borne out over more critical studies. So I don't think I'd recommend any of those. And again, as Amy showed earlier, there are certain foods which lower the risk for cancers, and probably also they lower the risk for polyps. So a low-fat diet, a high-fiber, Mediterranean type diet seem to be a possible mechanism to lower the risk for polyps and then for cancers.
That makes sense. So at what age do you stop getting colonoscopies, or how late in age should someone consider having one?
So the recommendation originally was to stop doing colonoscopies at 75, and just leave it at that. I think the fact that people are living longer and healthier, some people are now looking at that a little differently. So they're basically saying age 75 would be kind of your baseline, but between 75 and 85, it's really should be evaluated on a per person basis. So someone is a very active, healthy individual who, has no other major kind of problems. Yeah, you probably would say maybe you do a colonoscopy at age 78 or 82, maybe. I don't know if you necessarily push people to do a screening colonoscopy, surveillance colonoscopy at age 85, but I think that, probably somewhere in the 75 to 85 range you would stop. But that would be a person-to-person discussion, I think.
So I get that question sometimes in my office for two reasons. One is a person just who would be due for screening, or someone who has symptoms. And so what I often say to the patient is, if it's an 80-year-old, an 85-year-old, I say, if you have a colonoscopy and they find something, God forbid they find a cancer, would you want to have surgery to cure that cancer? And usually the answer is yes. And usually they'd be perfectly fine to undergo a robotic resection. And so I would recommend colonoscopy if they're having any symptoms. And if they're not having symptoms, the question is, do you plan on living a few more years? And is it worth it for you, if you do have a polyp, to remove it and prevent you from developing a colon cancer? And so if the benefit outweighs the risk for you, I think it's important to, I think they'll probably publish new guidelines soon, but now that everybody's, healthier and living longer, I think we really reevaluate that number. So I think somebody wrote, is prior history from past colonoscopies evaluated? So I would maybe rephrase that as, when you're doing a colonoscopy, do you consider the patient's prior findings on colonoscopy in your assessment?
So I'm not sure I totally understand the question, but I think, you would certainly look at prior colonoscopies, and that would be an important factor when you're determining whether you should do another colonoscopy. Also, if somebody had a polyp in a certain location and it was a bad polyp,
Right.
certainly, kind of focus in on making sure you look at that area more carefully. So I think That would be the way I would think about that.
Right, like if you removed a large polyp from one location and then you go back and you would check that area again to make sure that there's nothing regrowing in that area if it was large or had any other features. Okay, great. Well, thank you so much. And thank everyone for joining us tonight. So please complete the survey that's going to pop up on your screen immediately following this webinar. Your feedback is so important to us. I want to thank you all for joining us. And on your survey, if you'd like to be contacted to schedule an appointment, please share your name and number and our providers will contact you. Again, that's confidential information. Additionally, if you have a question you'd like to ask that was not addressed during our live presentation, please put your name, contact information, your question in the designated field, and someone will get back to you. Don't forget to get your colonoscopy. If you want information or to schedule an appointment with one of our providers, call the number listed or visit the website. Thank you so much for joining us and have a great night.
Good night.
Thank you.
Thanks.